We welcome all the participants who have logged in from all over India and even outside India as well. We thank for giving giving your time to and desire to learn through this platform. So without wasting much of time, just let us get into the session. So first speaker will be Dr. Adarsh. He is a founder director of OM Group of Hospitals, and he's going to talk on approach of congenital heart disease. As a clinician, as a neonatologist, what are the key things that you need to know? So it's going to tell in brief and make it simple about the approach of congenital heart disease. Followed by Dr. Ram Krishna. He's a consultant neonatologist and lead neonatologist practicing at SKS Hospital. He's got a vast experience in echo, and he's an excellent speaker, and we know him personally, and excellent orator as well. Thank you very much for making time for our session. Over to you, Dr. Adarsh.
Thank you.
Thanks, Prashant.
Today's session will be moderated by Dr. Vikas. He's again a cardiologist by heart and a practicing neonatologist and a chief neonatologist working at Motherhood Hospital, Sakar Nagar. Dr. Vikas, welcome.
Thank you. Thank you.
So he'll be moderating the session for today. Dr. Adarsh, are you ready?
I'm ready. Are you able to see my screen?
No. It's just coming as a video conference thing. Your Chrome link is come up. You open your thing from the background. Just minimize this. Yeah, you can take it out. Yeah. Now you share the screen and select PPT like the way you selected earlier.
Share the screen.
Yeah. Select the presentation there. Yes.
Perfect.
Yeah.
You can make it into.
Okay.
Yes. Over to you.
Thank you, Prashant. So, good evening, all. Let me give a brief approach or the congenital heart diseases and why do we do so. Later on, Dr. Ram will continue from where I left and will go on and talk about each condition more in detail. So let me talk about what is the burden which we are facing in India right now. So the incidence varies from book to book, but roughly it is 10 per 1,000 live births. To give PGs an estimate, 2.5 crore babies are born in India every year. So the number of congenital heart diseases should be anywhere between 2.4 to 2.5 lakh per annum. This is our Indian statistics. In this, 6 to 7 cases will be slower onset, will present with murmur, could be dealt little later on. However, 1/3 of the cases are critical and they will require intervention in infancy. This is very key. So 3 per 1,000 live births will require some kind of an intervention early. If these children are treated, the correct operative procedures are done, vast majority of them can go to adulthood, which is a very important fact. If you were to compare them with the neural tube defects or something, there are many things which we may not be able to do, even if you pick up antenatally after birth. Whereas in critical congenital heart diseases, a good pickup and treatment can lead to their survival. And we all know delay in diagnosis will lead to death or morbidity or both. So prompt recognition is going to be the key in this critical congenital heart diseases. So what is this definition of a critical heart disease? So American Heart Association says that any intervention of any child in the first year of life is taken as critical congenital heart disease. More practical approach is any child which required an intervention or resulted in death within the first 28 days of life can be called as a critical congenital heart disease. So I'll just mention some of the conditions which most of you have seen or read in your practices: tetralogy of Fallot, transposition of the great arteries, PVC, which is anomalous pulmonary venous connections, tricuspid atresias, Epstein's, truncus, single ventricle pathologies, then severe aortic stenosis, coarctation or interruption of arch, hypoplastic left heart syndrome. So these are some of the critical heart diseases which we should be cognizant about. So now in this current era, how does these congenital heart diseases present to us? So one is antenatal diagnosis or prenatal diagnosis, wherein even before the baby is born, the ultrasonologists or fetal echocardiologists pick up and will be able to reasonably tell the parents and inform the doctors who are going to deal with this pregnancy. Second is once the child is born, where the clinician picks up based on the clinical signs. And lastly, the screening methods, which is pulse oximetry screening, which I will be discussing more in detail as we go along. So I think these are the three ways in which a congenital heart disease is picked up in this current era. So prenatal diagnosis, how good are they to pick up? So again, this depends on obviously the skill of the fetal echocardiologist. So some of the countries like UK were saying they pick up 50 to 60%, which means they still miss 30 to 40% of the cases. In some other countries, it could be far higher. And again, in some of the countries, it could be lower. The key is, if you take Kerala government recently, they have passed a rule that there will be special workshops to all the people who do antenatal scans, which means they're going to train all the antenatal ultrasonologists to pick up cardiac diseases in the antenatal period, which is good. So this way, the number of cases detection can significantly go up. And whenever a prenatal diagnosis goes up, obviously this then cannot be delivered in a smaller place or a district general hospital. This mother has to be shifted to a tertiary care center, which would be the best possible outcome for that neonate. So prenatal diagnosis is going to be the most important because this will give the baby the best chance of survival. So postnatal diagnosis, once the baby is born, it's born to parents where there is no, all antenatal scans look normal. How does a clinician pick up? Age old things, murmur is one of the commonest we pick up, cyanosis, poor perfusion, which is absent femorals or lower blood pressures, baby present in shock, and lastly, presenting like a respiratory distress with cyanosis, fast breathing, and signs of pulmonary edema. So now I've put up a chart wherein, let us say, there is a delivered baby in the postnatal wards, and a doctor, let us say one of the PGs or a registrar has gone to the rounds, and they have picked up one of the following: a murmur, or they picked up there is cyanosis, or they picked up that it's very difficult to feel the femorals, or there is some slight dysmorphic features in the newborn baby. So these are the 3 or 4 things which a child seen by a doctor has picked it up. So the next step should be the consultant or the senior pediatrician or the neonatologist in the unit is involved. They should review the child. Let us look at this figure which I have put up, red, orange, green. The green is, apart from an innocent murmur, the baby is well. There is no signs of heart failure. The pulses are normal. The lower limb saturations are above 95%. So except for a murmur, rest of the baby looks normal. So this is a very reassuring case, maybe an innocent murmur. This child will need an echo, preferably by 6 weeks of age of the baby. So this baby will be appropriately referred for an echo scan. Other than the murmur, if at all the baby has some dysmorphic features, or the murmur is a pansystolic murmur, the grade is more than 3 or 4, 4/6, then this baby is actually referred a little earlier. Then the echo should be done within the first 2 weeks of life. The red, in the red zone, if there is features of heart failure, features of shock, if the lower limb saturations are less than 96, or if we are not able to feel the femoral pulses or even weak femoral pulses, this is significant congenital heart disease. This has to be referred immediately to a tertiary center. This is the key. So this chart is just giving you the green or amber and red, and the most important here is the red, which needs the immediate referral to a tertiary center. Talking about murmurs, I said that murmur is one of the most important thing in cardiology, but I have to tell that there are many conditions, critical congenital heart diseases, wherein there is no murmur. Some of them is transposition of great vessels with intact septum, an obstructed TAPVC, hypoplastic left heart. It may have a weak murmur till the ductus is there, and once it's closed, there may not be any murmur at all. Critical AS or PS, if um, the valve is so narrow, then there is no blood flow at all. Then there is again no murmur. Pulmonary atresia with VSD. So we have to be aware that congenital heart disease can present without a murmur as well. So that we have to be cognizant of. So first sign I said was about murmur. Second is cyanosis. So central cyanosis, which is defined as any saturations less than 85, which why I'm saying 85 is that is what is visible to the naked eye. Anybody less than 85% saturation, we can make that lips, tongue, or the peripherals, the nails will be blue in color. Second is when you keep SpO2 monitor, saturations anything below 90 is significant cyanosis, and we can increase the oxygen and see if the saturation is improving. In spite of giving 100% oxygen, saturations remain below 90%. Again, this is significant. If the unit, many units will not have echocardiography immediately, but most of the neonatal units will have an X-ray, and if they were to take an X-ray, X-ray could show up pulmonary oligemia, which is very, very less blood flow in the lungs. So cyanosis with pulmonary oligemia will point to some of the conditions, PGA, pulmonary atresia, or severe pulmonary stenosis, and these are critical and will require urgent referral. So cardiac cyanosis is one of the important feature. Third is systemic hypoperfusion. So these are conditions wherein the child will be relatively well on the first day of life, but as the duct starts to close by the second or third day, the child who was previously well without any features of, say, fever or premature rupture of membranes in the mother suddenly collapses. The collapse could happen even in the ward or in the house. This child will present with profuse sweating, cold clammy skin, you're not able to feel the pulses, tachycardia is there, there could be a gallop, all features of shock, and which is not responding to our traditional measures. When we look at an X-ray, obvious cardiomegaly is seen. Again, so these are normally seen in left ventricular outflow obstructions like severe aortic stenosis, coarctation of aorta, interruption of aortic heart, or hypoplastic left heart syndrome. So some of the babies will directly present as a shock type of features. Then there will be conditions such as TAPVC. These could present as very, very sick children. So they will have features of cyanosis along with respiratory signs such as tachypnea, tachycardia, chest wall retractions, and an X-ray could show a plethora or a ground glass appearance, suggesting that a lot of pulmonary edema is there in the lungs. Sometimes these conditions are also very, very difficult to differentiate between a respiratory cause and a cardiac cause, and of course, echo becomes a mandatory to clinch the diagnosis. So I've said sometimes identification of critical congenital heart diseases are difficult. I said some of the conditions may not have a murmur at all. Second, there will be overlap in presentations. Sometimes hypoplastic left heart or a critical ventricular outflow obstruction can present exactly like a septic shock. And we all know that septic shock is much more common in a newborn or a neonate as compared to a congenital heart disease. So we should not miss a septic shock as well. At the same time, septic shock not improving to traditional methods, we should think of left ventricular outflow obstruction type of lesions in the child. Again, pulmonary atresia or severe pulmonary stenosis can again present like a PPHN, again confusing the neonate whether it is a cardiogenic cause or a respiratory cause. So how do we manage and what do we do next? We are suspecting a congenital heart disease here and the case seems to be critical. Of course, whichever center they have a chance to get an echocardiogram, that would be the best. Echo will clinch the diagnosis. In the meantime, they can start the standard neonatal management of stabilizing the child, which I will not be going into details. Prostaglandin even. So two things which we have to be very, very important: duct-dependent pulmonary circulation and duct-dependent systemic circulation. These are the two conditions where we should use the prostaglandin infusion, and that is beneficiary. So in duct-dependent pulmonary circulation, there is reduced pulmonary blood flow because of the stenosis or atresia, and the ductus arteriosus. This is the only source of the blood flow between the lungs and the system. So as soon as the duct closes, the child will collapse. So a blue baby with black lungs. This is the key mnemonic. Blue baby, black lungs, which means oligemia, is one of the important reasons where you should immediately start PGE1 prostaglandins. Duct-dependent systemic circulation, these again I mentioned before, the left heart obstructive lesions like severe aortic stenosis, coarctation, interruption of aortic arch, or HLHS. Again, these present within the first 2 to 3 days of life. The key features, I'm repeating them: absent femorals, saturation difference between the pre and post ductal SpO2, which is right upper limb versus lower limb saturations, and a sudden collapse. Again, these children do benefit from PGE1. If we are in doubt, we could start a small dose, 30 to 60 nanograms, which is around 50 nanograms, and see whether the child is improving. If it is a duct dependent lesion, the child will significantly start improving, and immediately the neonatal unit should start planning for a transfer of this child to a tertiary neonatal unit. Transport, I said we have to transport, but this has been an Achilles heel. It's very difficult to transport these babies sometimes from smaller centers, tier 2, tier 3 cities, even in tier 1 cities. Unless there is a specialized transport with abilities to intubate and ventilate a child, we will still struggle to transport cardiac children. If we look at some of the data, especially from tertiary cardiac centers, they have said the condition of the neonate at admission was the single most important factor determining outcomes, which means any delay in diagnosis or not a good transportation still will not have a very good outcome in spite of best surgical interventions for the baby. So it is very important to diagnose this early, and if possible and if needed, start on prostaglandin early and transport these children at the earliest to a tertiary referral unit. Now, I want to talk about pulse oximetry screening. So this has become one of the very important tools in picking up congenital heart disease, and it is an objective and a very simple and a reliable tool. With this, we can easily pick up things before they are bad. Once early diagnosis is made, appropriate referral could be made. With this, our limited resources could be appropriately used. So let me talk about POS screening guide. So this is a chart we have taken from American Academy of Pediatrics. So every child who is born and who has completed 24 hours of age, the child has to have a pulse oximetry screening of the right hand and the foot. Now, any child which has a saturation of less than 90, automatically they go for a referral. Any child which has a saturation of greater than 95 and no difference between the upper and lower limbs, they do not need to do anything. They have passed the test. Children who are between 90 to 95, it is repeated after 1 hour. Again, between 90 to, if it comes between 90 to 95, we repeat it again after 1 hour. In spite of two repeat, if the saturation is again only between 90 to 95, this means that it could be mixed lesions, wherein there could be a congenital heart disease, but adequate blood mixing is happening so that they are not in collapsing, but early signs which we could pick up. So these children, when they are well itself, we could appropriately send them to the tertiary units. So all doctors here who are listening to this webinar, we should make pulse oximetry screening across all over India as mandatory. Every child who is born after 24 hours, we should be able to see their saturations both in the upper limb and lower limb and record. As I said, anybody coming in between 90 to 95, we repeat that test in the next 1 hour. Next two times also it is coming the same. This child will be seen by a senior and then appropriately referred to the tertiary unit. Now, if I were to look at antenatal screening, postnatal diagnosis, and pulse oximetry screening, probably pulse oximetry screening is the most easiest method to diagnose congenital heart disease in the newborn. So this chart I've taken from an American hospital, Healthcare of Atlanta, which is available. It is called as Pulse Ox tool. Any of you could go into the web and you could see it. Whenever you've done the SATs, there is a column called hours. You can say whether it's the first attempt, second attempt, third attempt, and you could write the saturations of the limbs, upper and lower limb, and compute. Immediately, the machine will tell us whether it is the baby has failed the test or passed the test. If the child has failed the pulse oximetry screening, this is the baby which directly reads a referral. So with this, what are our Indian challenges and what do we do? So one, we should emphasize on prenatal diagnosis. That is number one. All the practicing radiologists and ultrasonologists who do fetal and antenatal scans, they should get workshops to especially pick up fetal anomalies or fetal cardiac anomalies. That itself will go a long way in picking these conditions antenatally, and so that the mother in utero could be transferred. That is number one. Second, many of the practicing pediatricians, we see cardiac cases very few and far. So there will be a great difficulty in picking them up when we are suddenly encountering a case. So focused workshops, especially places like NF, should push focused workshops on picking up congenital heart disease. So this will enable the pediatrician to pick them up at the earlier time. I think all units should have prostaglandin E made widely available so that once they have made a diagnosis, they should be able to start them on prostaglandin, keep the duct open, and be able to refer them to the neonatal units. Transport, yeah, some of the units may have good transport, but largely throughout this Karnataka state, there is a lot of emphasis to be put on neonatal transport, where we should be able to transport these critical cases from smaller centers to the regional centers. And in every place where newborn deliveries happen and neonatal units, pulse oximetry screening should be made mandatory. I think these would be my recommendations going forward. See, it's very important. We're all looking at ways to reduce neonatal mortality rate and so hence infant mortality rate. The critical congenital heart disease itself, if we solve them well, the neonatal mortality can come down by 2 or 3 numbers for every 1,000 live births. Thank you.
Thank you, Dr. Adarsh. So we'll take up all the discussion and questions after the end of all the presentation. So you can stop sharing the slides now.
Okay. Let
Dr.
me do
Ram?
that. Okay.
So, Dr. Ram? Dr. Ram?
Yeah. Can you hear me?
Yes. You can start your.
Yeah. You can hear me, right?
Yes. I can hear you. All right. You can start sharing your slides.
Yeah. Right. 1 second. So can you see the screen?
Yeah. It's good. You can enlarge. Yeah. Slideshow. Over to you. It's going to talk on point of care ultrasound, that is echo. What a neonatologist and pediatrician should know regarding congenital heart disease. Over to you, Dr. Ram.
Thank you. So, I totally agree that clinical examination and the pulse oximeter screening is very, very, very important. And it picks up majority of the cases of congenital heart disease. The final confirmation is by echocardiogram. The echocardiogram done by a pediatric cardiologist is finally conclusive. But the practical issue is finding a pediatric cardiologist in all the places, in wherever we need and at whatever time we need. That is the most difficult issue all over the world. And hence, neonatologists and pediatricians have started doing point of care echocardiogram. So I am going to concentrate on what neonatologists and pediatricians should know when they are scanning the heart as a sort of screening echocardiogram. So over the next 30 minutes, I'm going to talk about how normal echocardiograms look like and how does it look whenever you're scanning a congenital heart disease, particularly cyanotic heart disease. How does acyanotic heart disease look like on echo? And rare heart diseases, what do you see on echo? And practical tips and take-home messages. So the aim is, number one, baby safety is of whatever we do in whichever form of medicine, whatever branch of medicine, the patient safety is of prime importance. So we have to always bear that in mind. And our aim is to identify any abnormal appearance. We are not expected to make a diagnosis just like how a cardiologist does. Basically, we are supposed to identify any variation from the normal and then try to figure out what is happening. And with the help of the pediatric cardiologist, we make the necessary plan for the baby. And that is to keep the baby safe. And the next important thing, as Dr. Someshekar talked, is we have to identify whether it's duct dependent or not, and whether prostaglandin should be started or not. However, if there is, if you suspect that it could be a congenital heart disease, if echocardiogram facilities are not available, sometimes it may be better to start the prostaglandin, and following confirmation by echocardiogram, if it's not a duct dependent lesion, the prostaglandin can be stopped at any time. So just bear that in mind. So watch out for subtle clues. That's the first thing. So whenever you scan the baby in the abdomen, when what you're looking for, focus on whether it's situs, whether the IVC and the aorta are normally placed, whether normally you see the IVC and the aorta in the abdominal views. Just check whether there is any additional vessel coming between the inferior vena cava and aorta, because that will I will show you some videos that will suggest that this baby may have a TAPVC. And atrial septum, you always have to concentrate on the atrial septum. And what is the location, or where is the atrial septum located? And what is the direction of the flow through the atrial septum? That is very, very important. And watch in the abdominal view, in the subcostal views, you look for pulsatility of the aorta. So the aorta should be nice and pulsatile, and the blood flow should be smooth. It should not have any diastolic flow. It should have only systolic flow. And look for the chamber size. In the 4-chamber view, where you see the right atrium, left atrium, right ventricle, and left ventricle, look. Hello, there is, you have to mute. Yeah, okay. So look for any discrepancy in the chamber size. Ideally, if a chamber is bigger, then it somewhere during the development or antenatal period, that particular chamber has received more blood flow. That may be the reason why the chamber is bigger. And if that chamber is smaller, there may be a possibility that that chamber has received less blood flow. So you have to keep these things in mind when you're looking at the echocardiogram. If a chamber is big or small, just try to find out why it has been big or small. And sometimes you find tricuspid regurgitation on echocardiogram. Usually tricuspid regurgitation implies that the pulmonary pressures are high, and probably you might have heard in your previous classes that you can calculate the pulmonary hypertension based on your tricuspid regurgitation jet. But always don't brand that as pulmonary hypertension without trying to find out why is this baby having the pulmonary hypertension, or why is there tricuspid regurgitation. And the valves, any valve should appear and disappear in different parts of the cardiac cycle. For example, if the ventricles are contracting in systole, the valves open, so they should disappear on echocardiogram. And when the ventricles are relaxing, the valves close, particularly the aortic valve and the pulmonary valve, and they should appear on echocardiogram. And always ensure that there is forward flow through the outflow tract. So whether it's right ventricular outflow tract or left ventricular outflow tract, make sure that there is blood going through, and don't get fooled by a PDA flow, and don't assume that it is forward flow. I will come back to that in a video. And the aorta and the pulmonary artery, they are not in the same plane. So at any given view, you should not be able to see these two outflow tracts parallelly. They should not appear parallel. You should see one after the other, right? But due to some reason, if you're seeing parallel outflow tract, you always suspect whether there is a transposition of great arteries. So what to do now? You have gathered all this information, and basically you have various pieces of puzzles together, and you have to put all the pieces together and solve the puzzle. That is the trick. You may not get the diagnosis right, but as far as you're able to find out variations in the pattern and collect all the information, and you can image those, you can now with WhatsApp and FaceTime, you can send those images to cardiologists, you can get their help in arriving at a diagnosis. If the pattern is abnormal, always seek help. Now, is this a duct-dependent circulation? So this is the next question you need to ask, for that which I will show you some videos. Now, what is normal, right? So look at this one picture alone. This one particular picture where you see the spine in yellow color, and then the IVC in blue color, and the aorta in red color. So usually when you're doing the abdominal view, the IVC should be to the right of the spine, and it should be anterior, which means above the aorta. And the aorta should be to the left of the spine, and it should be posterior. So this is the normal pattern. If you're seeing this pattern, that's perfect. If you're seeing any other pattern, then note that information and discuss with the cardiologist. So basically it's pattern recognition, right? Now, this is the abdominal vessels. You can see that in this video, the IVC is here, and this is the aorta, and this is the spine, right? This pattern is a normal abdominal situs pattern. And then what you see here is, this is the right atrium here, and you see the hepatic veins coming and joining here. Now, the small vessel that you saw earlier, this IVC, you should ensure that it connects to the right atrium. So this is the IVC here, and you have to ensure that this IVC is connecting to the right atrium and there is flow through that. So this rules out interrupted IVC and all those conditions, right? And the next thing you see in this subcostal view or view from the abdomen is your aorta, right? So the aorta has to be nice and pulsatile, and there should be blood flow in the form of a Doppler color flow in the aorta. In this case, you can see an umbilical artery catheter sitting inside the aorta. So that shows that that's the aorta, and the pulsatile aorta rules out coarctation. Now then concentrate on the atrial septum. So this is the right atrium here, and this is the left atrium here, and this is the interatrial septum. So as I told you earlier, look at the position of the atrial septal defect or a PFO, and always look at the direction of flow. If it's a pure red flow across the septum, you call it as a left to right shunt. If it is a pure blue flow, it is a right to left shunt. And you see blue and red flow, it's bidirectional shunt. Now, whenever you see pure blue flow, it is definitely abnormal and you should seek a cardiologist's opinion, because pure blue flow means that the blood is flowing only from the right atrium to the left atrium, and unless the baby has severe pulmonary hypertension or transposition of or you have your anomalous pulmonary venous drainage, this doesn't happen. So you need to make sure that the pure right to left shunt you need to discuss with the cardiologist. And the next thing, this is the video showing the shunt. Here you see the position of the shunt is a bit higher up on the atrial septum, and this is pure red flow, which is acceptable, right? And then look at for the chamber size. So here the right side is slightly enlarged when compared to the left side, but sometimes in the beginning, newborn babies, when the right side pressures are high, the right side may be slightly enlarged, but make sure that there is no other abnormality associated with that. On the next one, the first vessel that comes out of your left ventricle is your aorta. The first vessel that you should see when you tilt the probe up from your apical view is your left ventricle, right? So that shows that that's the aorta here, and you can see nicely that the tricuspid flow, the blood flow is flowing from the right atrium to the left atrium, and the blood flow is also, the blood flow is going correctly from the right atrium to the right ventricle and from the left atrium to the left ventricle, and the aorta, origin of the aorta can be seen there. And in this view, again, the same view, you see the ascending aorta here, and which has a nice blue laminar flow. That is very important to make sure that there is no turbulence or obstruction. So this view, you look at for any outflow tract obstruction on the left-hand side, and whether left atrium gives rise to the, left ventricle gives rise to the aorta and not the other way around. And then when you tilt up further, you see your pulmonary artery. Here, you see the pulmonary artery that is coming out from the right ventricle. So, as I told you, both the vessels should not be seen parallel together. One, you should see one first, and then you should see the other one next. Hello? Yeah. So then the next one is your Your next one is your parasternal views. And in the parasternal views, again, you look for any parallel vessel arrangement. Here you're able to see only the aorta here, and on top of that you see the right ventricle. You should not see both the pulmonary artery and the aorta in the same view. And then when you tilt up further, you see your pulmonary artery here, and so as I told you, you should not see both together at the same view. And this is the PDA you can see here in this view. So here you see the left pulmonary artery, and then you see the duct which is seen here. So the PDA and the duct, the left pulmonary artery and the PDA can be seen in this view. The left pulmonary artery and the PDA. And then next one you look for is for pulmonary veins, right? So in this view, you see the left atrium at the bottom, and you can see 2 red flow and 2 blue flow. So the 2 red flow are the left are the lower pulmonary veins, and the 2 blue flow from the top are the upper pulmonary veins. So 4 pulmonary veins you have to see to ensure that the pulmonary venous drainage is good. And finally, you concentrate on the aorta. So you should see a nice aorta without any obstruction, and you should be able to see all the branches in the aorta, right? The branches should be very clear, and there should be no obstruction, and the aorta should have normal laminar flow, blue flow without any turbulence or obstruction. So these are the normalities. Now, just to recap, duct-dependent systemic circulation, right? As Dr. Someshekar said, coarctation of aorta, hypoplastic left heart syndrome, critical interrupted aortic arch. All these things are duct-dependent systemic circulation. And duct-dependent pulmonary circulation are, number 1, critical pulmonary stenosis. Remember, mild and moderate pulmonary stenosis do not come under duct-dependent pulmonary circulation. Only the critical pulmonary stenosis comes. And if there is a pulmonary atresia with intact ventricular septum, any tricuspid atresia, tetralogy of Fallot. Again, most of the tetralogy of Fallot, if the pulmonary stenosis is not severe, they are usually asymptomatic. But if the pulmonary stenosis is severe, then it can be a duct-dependent circulation. And severe Epstein's anomaly due to functional pulmonary atresia, because the valve is placed very, very low, the tricuspid valve, and there is no space for the right ventricle to fill. So basically, it behaves like a pulmonary atresia. On the duct-dependent mixed circulation, like transposition of great arteries and the total anomalous pulmonary venous drainage. Now, TAPVD, many cardiologists suggest not to start prostaglandin, but for neonatologists and pediatricians, until we are certain that the diagnosis is only TAPVD and nothing else, there is no harm in starting prostaglandin if in doubt. And if the cardiologists say that it's definitely TAPVD, we can stop the prostaglandin. So we'll just look at the videos of some abnormal cyanotic heart disease. Right now, this is a video.
Ram, can you use a different color pointer? Ram,
sorry,
can you use a different color pointer? If you can change the pointer.
Is it possible? I don't know whether it's possible.
Or you can use over there down. On
which one?
And I mean, there is a pen is there, no, on the left lower end corner.
Pen, no?
Yeah.
Where about?
On the left lower end corner, on the share screen, the slide presentation is there, no? Left lower end corner of your Mac.
1 second, I'll just see. Left lower end corner, I'm not able to see any.
You'll have a, you can write it over the screen. That on the, if you can.
Oh, you mean? It's a bit difficult, I think. Right over the screen now.
No problem. Use the same thing, but slowly you move and you show them because a lot of.
Yeah.
Okay. Carry on. Sorry to interrupt.
No, that's fine. Yeah. Okay. So the parallel vessels in TGA. So you can see here that see there is a one vessel coming out and another vessel coming out. So basically, this is a TGA where you see the parallel arrangement of the vessel. Only in TGA you will be able to see this, and not in any other pathology, right? Okay, and the next thing is, again here in the transposition of great arteries, I told you the first vessel that should come out of the left ventricle should be your aorta, but here you can see the branching pulmonary artery. The branching pulmonary artery is coming out of the left ventricle, suggesting that this is a transposition of great arteries. Okay, and the next one is, here you can see there is a ventricular septal defect here, and the aorta is sitting on top of the ventricular septal defect. This is called as an overriding of the aorta, right? This is seen in tetralogy of Fallot, and another component of tetralogy of Fallot is your pulmonary stenosis, which is not seen in this video, but this is classically a perimembranous VSD, right? If the VSD is in the bottom, it's a muscular VSD, whereas if the VSD is in the top, in this area, it's a perimembranous VSD. Here you can see the overriding of the aorta. And here, this particular video, you can see the left side is smaller. The left ventricle is very, very tiny when compared to the right ventricle. And the mitral valve is not even opening. It's very, it's very atretic. It's not normal, the mitral valve. Whereas the tricuspid valve is opening and closing normal, right? The mitral valve is not opening fully. And it's a very small left ventricular cavity. And if you look at the arch of the aorta, here you can see the proximal arch is narrow when compared to the distal arch here. So there is hypoplasia of the ascending proximal arch of the aorta. So basically a combination of mitral atresia, small left ventricle, and hypoplastic proximal arch is what you call it as hypoplastic left heart syndrome. This is definitely a duct dependent circulation. And here what you see is the right ventricle is very small, and the tricuspid valve, the mitral valve is opening and closing normally, but the right ventricle is very small, right? And that suggests that the flow has not been happening properly in the antenatal period. So small right ventricle, and if you see here the cross-sectional views, so look at the size of the aorta, which is huge, whereas on top you see a small pulmonary artery, right? See here you see a small pulmonary artery here, and the valves are thick, right? So this is basically a pulmonary atresia.
Sorry to interrupt.
Yeah. Hello.
Ram, can you mention the views, because the audiences would like to know the views that you're actually using for each of these.
Yeah. So this is the parasternal short axis views where you see your aorta and the pulmonary artery normally. So here basically a slight tilt from the parasternal short axis, you angle it slightly and you get this view. And in this view, you see that the aorta is huge, but the pulmonary artery is very, very tiny, and the valves are thickened. So this is basically a pulmonary atresia. Okay. And the next view is, in this case, you can see the tricuspid valve. This is the apical four-chamber view, and this is the tricuspid valve, and this is very thick. and it's not opening properly at all. Whereas the mitral valve is opening, right? And the right ventricle is small, and what you see here is mostly left ventricle, right? So basically, this condition is tricuspid atresia. So this is how you, based on the chamber size and whether the valve is thickened, whether it's opening or not, you suspect whether it's tricuspid atresia or pulmonary atresia, all those things. Now, the next one, this baby, clearly you can see this is the apical four-chamber view, and you can see there is severe tricuspid regurgitation. Now, clearly the pulmonary pressure, the tricuspid pressure, the pulmonary artery, estimated pulmonary artery pressure will be very high if you get a severe tricuspid regurgitation like this. But as I told you, always ask, why is the pulmonary pressure very high? Is there any obstruction to the right ventricular outflow tract? Does the baby have coarctation? Because sometimes in severe coarctation, there may be pulmonary hypertension. So without ruling that out, do not put the diagnosis of pulmonary hypertension and just treat pulmonary hypertension, right? Make sure that there is no cardiac defect. So with this amount of tricuspid regurgitation, if you look at it, this is a subcostal view where you tilt further to see the chambers on the outflow tract. And you see here the pulmonary valve is very, very thick, right? And there is turbulence in the forward outflow tract flow. So there is some turbulence in the flow that is going out of the pulmonary valve. And if you look carefully, it's not actually forward flow. Basically, what is happening is the duct is coming there and it's hitting the pulmonary valve and turning back and going. So basically, that is what is appearing like forward flow. So this is basically, either you call it as critical pulmonary stenosis, the forward flow is very, very minimal, or pulmonary atresia. These ones the cardiologist will differentiate. But in these conditions also, you will get high pulmonary pressure. So there have been instances where people have just branded it as pulmonary hypertension and people are treating it with inhaled nitric oxide. And then finally a repeat echocardiogram had shown that it's critical pulmonary stenosis and not just pulmonary hypertension. So we have to be very careful in these things. And this baby had right ventricular, the pulmonary pressure or tricuspid regurgitation gradient of 97 millimeters of mercury, which is critical pulmonary stenosis, right? Okay. On the next one, in the subcostal view, I told you, this is the aorta that you see here. This is the aorta that you see here. And normally you see the IVC in the other view, to the right side of the subcostal view. But here you are seeing a big vessel that is coming in between the aorta and the IVC that you don't see here. So whenever you see such big vessel, you suspect, anomalous pulmonary venous drainage. In this particular condition, whether it's an infracardiac total anomalous pulmonary venous drainage. And when you put the Doppler flow, it's definitely a venous flow, right? It's not an arterial flow. It's a continuous low velocity flow, which is a venous flow. And then if you do a bicaval view, so this is what you call it as a bicaval view, where you see your superior vena cava coming from the top and the inferior vena cava coming from the bottom. And you have the right atrium in the middle, right? And in this bicaval view, along the inferior vena cava, you can see a vertical vein. All the four pulmonary veins, they are forming a confluence behind the heart. And they are coming down as a descending vertical vein and joining into the inferior vena cava. So this is basically what you see in an infracardiac PA-PVC. And I told you before, whenever you see a atrial septum, always concentrate on the position of the atrial septum and also the direction of flow. So in this atrial septum, the position is to the top and the direction of flow is pure blue flow. It is basically a right to left shunt. So you always have to suspect total anomalous pulmonary venous drainage if you see this. This is a subcostal view tilted slightly up, you can see the atrial septum, right? And this is another subcostal view, particularly focusing on the right atrium here. You have the left atrium, and there is a membrane-like thing. You know, normally you see the pulmonary veins draining into the left atrium, but here what's happening is there is a membrane-like thing here, and what's happening is these 4 pulmonary veins are forming a confluence here, and then they're joining into the superior vena cava. So this is the classical supracardiac TAPVC, and where you see an ascending vein in this condition, right? Okay, and the next one is, this is again a large coronary sinus, which is so huge. Whenever you see this is again the 4-chamber view, slightly tilted, and if you turn posteriorly, you will see the coronary sinus. And normally the coronary sinus will be only up here, up to the arrow mark here. Normally, whenever you see a coronary sinus this big, you suspect 2 things. Whether it's a left-sided SVC, some babies have bilateral SVC, and sometimes the left SVC will drain through the coronary sinus into the right atrium, or there can be a cardiac TAPVC. So you've seen supracardiac TAPVC, infracardiac TAPVC, and this is a cardiac TAPVC that can present like this. And the next one is, this is the parasternal short axis view. And here you see the aortic valve. Normally you see a Mercedes-Benz tri-leaflet aortic valve, but here you are seeing a bicuspid aortic valve. It's not the classical tri-leaflet aortic valve. Now, whenever you see a bileaflet aortic valve, it can be a normal variant, but always look for associated findings, particularly coarctation, right? So this baby has, you can see there is a narrowing of the aortic arch here. See, the aortic arch, the proximal arch is a bit wider, and at the area of the isthmus where the PDA would have normally been there, that area is a bit narrow. And when you, so you can see anatomically it's narrow even without color. And when you put the color Doppler, you can see there is a restriction in the flow in that area, and there is also some turbulence, right? It's a restricted flow. This is coarctation of the aorta. You can see the difference between the ascending aorta and the transverse aorta flow, which is huge, and the descending aorta flow, right? So this is coarctation of aorta. And the next one, truncus arteriosus. Again, this is rare. Again, this is a cyanotic condition. Here you see the left ventricle, this is the parasternal long axis view. You see the left ventricular outflow tract, right ventricular outflow tract, and there's a common outflow tract here, and the valves are all common. So this is an abnormal truncal valve, and you can see in these abnormal truncal valve there will always be stenosis and regurgitation. There will be both turbulence, stenosis, and backflow. So truncal valves are always abnormal, and they will have stenosis and regurgitation. So this is truncus arteriosus. And this is also rare. You can see in this video, the ascending arch and the transverse arch is there, but after that you are not able to establish flow. The flow stops after the ascending and the transverse arch. And then the descending aorta is supplied by a huge PDA. So whenever you see a very huge PDA, always ask, there should be a reason for this huge PDA. And nature has kept the PDA open for the baby to be alive, so that you have the time to scan the baby. Only when the PDA closes, the baby starts to have symptoms. So whenever you see this is the right pulmonary artery here. This is the left pulmonary artery, and this is the PDA. And the PDA is the size of bigger than the left pulmonary artery, and it's continuing as aorta. So this is interrupted aortic arch, because the proximal ascending and the transverse aorta is not continuing down, it's interrupted there, and PDA is continuing down as an interrupted aortic arch. That is, and you can see clearly red and blue flow in the PDA, right? And this one is an apical 4-chamber view, where you can see right atrium and the left atrium. But at the same time, the tricuspid valve is not in the normal place. It's placed well below. And the right ventricle is only tiny. So this is your classical Epstein's anomaly, which is the atrialization of the right ventricle, right? This is your Epstein's anomaly here. So these are the cyanotic diseases which we have seen. Now we'll look at the acyanotic diseases. So the commonest one, we all know, it's a ventricular septal defect. Here you can see in the lower down, there is a flash of red flow. Because the pressure on the left side is greater than the right side, it's a left to right shunt, and it's a muscular VSD. This is a small VSD which will close spontaneously by itself. And if it's there in this part, it's a perimembranous VSD, whereas in the lower part, it's a muscular VSD. And this is a perimembranous VSD. You can see here, this is in the perimembranous area in the upper part of the septum. And this is unlikely to close, right? And the color Doppler of this perimembranous VSD, you can see the wider Doppler flow, and you can see a left-right shunt coming here. And this one is the atrial septum. And this atrial septal defect, you can see it's in the location of the foramen ovale, but the size of this atrial septum is 3.3 millimeter, roughly anything more than 3 millimeter. And without a flap, it is an ASD when compared to a PFO. So if there is no flap, and if the size is more than 3 millimeter, we call it as atrial septal defect. And it's unlikely to close spontaneously like a PFO. It can close after 2 to 3 years, but it needs to be followed up every 3 months by a pediatric cardiologist. Okay, and this is the direction of flow through this atrial septal defect. You can see large left to right shunt through the atrial septal defect. And usually atrial septal defects do not cause symptoms in the first couple of years. They usually start to show symptoms only after 2 to 3 years of life. And now this is the atrioventricular septal defect. You can see the atrial septum. This is a apical 4-chamber view. Atrial septum is falling short here. It's not completed. It's not coming and reaching the midline. And the ventricular septum is also falling short here. And there is a common valve here. There is no separate tricuspid and aortic valve. There's a common AV valve. So this is the atrioventricular septal defect. And the next acyanotic disease, I told you, only if it's a critical aortic stenosis or pulmonary aortic stenosis, they will be blue, and that's cyanotic. Whereas, see here, you see the turbulence. See, this is the apical 4-chamber view, which is getting converted into apical 5-chamber view. So basically, you're tilting up the probe, and you're seeing the aorta coming out. And you can clearly see there is a turbulence in the ascending aorta, in the proximal aorta. And this one is aortic stenosis. This is the aortic stenosis turbulence. And if you look at the gradient, the aortic stenosis gradient is 52 millimeters of mercury. So 52 millimeters of mercury is moderate, more than 60 millimeters of mercury is critical aortic stenosis, right? So these are the rare cardiac defects. This is chamber enlargement, and the left side is enlarged. And here in the subcostal parasternal view, you see the aortic ring, which is not complete. You see the pulmonary artery, which is opening up here. This is called the aortopulmonary window, where there is a flow across this gap. And the next one is large chamber, the rare condition, but as neonates, you can see in the neonates with very poor left ventricular function. And when you screen carefully, this is the parasternal short axis view. You can see this is the aorta, this is the pulmonary artery, and your left coronary artery is coming up from the pulmonary artery, not from the aorta. So this is called as anomalous left pulmonary artery, left coronary artery from the pulmonary artery, Al-Kappa. So this is your Al-Kappa, right? And rhabdomyoma, this is a huge tumor sitting in the left ventricle. And this is a neonatal rhabdomyoma, where you can see, in tuberous sclerosis patients. And this one is a pericardial effusion. You can see clearly this baby has pericardial effusion, and whenever the baby has central line in, you have to look for pericardial effusion to ensure that there is no tamponade. And this is a dilated cardiomyopathy, very dilated left ventricle, poorly functioning left ventricle, whereas hypertrophic cardiomyopathy will appear very thickened interventricular septum. This is a slightly bigger child, thickened hypertrophic cardiomyopathy. And this one with central lines and infection, you see this is a huge vegetation sitting in the tricuspid valve. This is an infective endocarditis, fungal infective endocarditis. So this is the, these are the basics, cyanotic, acyanotic, and rare heart diseases. So the practical tips are, we have to remember that we are not cardiologists. What we are doing is functional or screening echocardiogram. We have to learn to troubleshoot and ask for help. I think we always have this overconfidence when we start doing it. Sometimes we feel that the cardiologist may think that we are not good. So we may not ask for help, but beware of ego and overconfidence. That's where we make mistakes. And the next thing is pattern recognition. So like ECG, if you see 20 ECGs every day, then you will be able to recognize it quicker. But if you see once in a year, then the same ECG, you need to go through it for longer period. Similarly, if you do more frequent screening echocardiograms and discuss with the cardiologist anything abnormal, then your skill improves very quickly. Thank you, and hope you're all awake. Thank you very much for the opportunity.
Yeah. Thank you, Dr. Ram. So I request Dr. Vikas to moderate the session, and there are a lot of already queries and questions which has already come up. Dr. Vikas, over to you.
Thank you very much, Dr. Adarsh and Dr. Ram. It was really a very nice session, and which took us through a lot of things.
Thank you.
There are a lot of questions which actually are addressed to Dr. Adarsh, and it's actually a lot on Dr. Adarsh. You're there, yes? Dr. Adarsh, can you hear me?
Hello, can you hear me? Yeah.
Yes. So there are a lot of questions for you to begin with. The thing is, it's all on prostaglandins. That is the PGE1. Now, the first, I'll club all of them together so that you can answer in one go. Now, is caffeine required before we start? What saturation do you start at? Do you intubate these babies? And what are the contraindications for starting PGE1?
So I think at 50 micrograms dose, the baby will not require intubation. But I know that as the dose is increased, say 100 or something, child may go into apnea, and intubation and mechanical ventilation is required. If you have done that, it is a duct dependent, either a pulmonary circulation or systemic circulation, then starting prostaglandin is compulsory. At higher doses, ventilating it is compulsory. What is another question, Vikas?
Caffeine. Do you start caffeine?
Caffeine, I'm not
because,
sure.
The PGE1 causes apnea. Apnea and hypotension are one of the most commonest side effects. I think that is why they're asking that. Whether would you start caffeine to prevent apnea so that you can get away with intubation?
I don't think so. We have to intubate and mechanically ventilate.
Any saturation that you would like to start these the prostaglandin?
What is the dose we start?
No, what is the saturation? Saturation, like 90%, 85%. Where do you start prostaglandin?
It's two ways, right? Once if you have diagnosed that it's a duct dependent lesion, you please start it and try to keep the saturations between the range of 90 to 95. Keep the dose as minimal as possible. At least the saturation should be above 90.
Hello, can you hear me?
Yes, Vikas. Is there something you wanted to add on?
Yeah, so there's another question which says, why right upper limb and lower limb? Why not the other way around, or the left upper limb and left lower limb? I think this is one of the PGs has asked. Is why do you actually take for right upper limb? And I think it's a very good question actually.
So the ductus, if you look at the arch of aorta, you know that at the left subclavian, at the junction there is where the ductus is. So the left hand, the limbs are all post-ductal, and only the right hand comes as pre-ductal.
Perfect. There was a question also on timing of pulse oximeter, because I think most of the studies have said it's 24 hours. So do you think 24 hours or a little later or a little earlier? And the other question which related to pulse oximeter, because there was a lot of talk on pulse oximeter and its importance, was will it pick it up coarctation of aorta? Timing, what is the timing of the pulse oximeter? 24 hours, 36 hours? Do you want to do it early, late? And will it pick up coarctation of aorta?
See, now let us get into the practical part. Most of the normal deliveries across our country will be discharged by 24 to 36 hours. If there was a protocol that we will screen everybody at 48 hours, we will surely miss a large number of normal delivery babies. When you screen at 24 hours after birth, I do accept there may be some of the false positives, but it is still better than missing them. So the guideline should be that it has to be done after 24 hours, anytime after 24 hours, or if at all the patient is going before 24 hours, then let us do it just before they go home. That should be the protocol.
Yes, and I'd like to add also that the sensitivity is about 76 to 77%, whereas the specificity is high. So if you pick it up, then it is definitely a problem, but you can always, there are chances that you can miss it. And that is why Dr. Adarsh was very keen on saying that there are three components for approach for congenital heart disease, which is the prenatal diagnosis, the clinical diagnosis, and the pulse oximeter tool. All three have to be incorporated. I do have one question from my side, which is regarding the availability of PGE1. What do most hospitals use? And I think if there's anybody in the chat also they can put in. But what is the most commonly used PGE1 that people are using? And its availability, because I think there have been instances when availability has been an issue, and I don't know whether all the hospitals have it, because all neonatal hospitals should have a PGE1 available at all times as an emergency, though you may use it once a year or you may not use it at all because it's a life-saving drug. Is there a availability? Yeah, somebody has typed in, Dr. Janki has typed in injection prostatin is easily available. Any particular brand that people use? Because we use Alpostin, yes, the same thing. So we use Alpostin. That's one of the brands that is used. There have been a lot of questions. I'm getting it's Sun Pharma is it's available. Thank you very much. On Dr. Rama, regarding the echoes, a lot of questions actually, and I'm trying to put it across. In first thing they was asking about nobology. It would have been helpful if they would be aware. I just will share a couple of slides with the speaker's permission, which will help in understanding, for the beginners, what might be the useful. If I can, I can share screen.
You can share screen. Just open up the presentation first.
Yep.
Then you share the screen.
Yeah.
Do that. Meanwhile, I request Dr. Dinakar sir.
Yeah, yes, Prashant.
Would you like to add anything, sir, with the present discussion?
Yeah, let Dr. Vikas keep on asking the question. If anything I can add, I will definitely.
Yes, sir. There is actually a lot that I think.
Questions they have asked. What all the views in the subcostal, whether we can do pulmonary, all those things are there.
Correct.
In case if we can add, definitely I will add it. Let the speakers go ahead.
There was one question on the different positions that you'll be using for different views. So in the sense for different pathologies.
Yeah, Dr. Ram.
Dr. Ram?
Can you unmute me? Unmute me, please.
You're unmuted. We can hear you.
Yeah. Okay, so the question is different pathology, different windows for different pathology.
Yes.
Which windows? Okay, so the subcostal views, you look for situs, right? And abdominal situs mainly. And you look at whether the SVC is connected to the right atrium, IVC is connected to the right atrium, and the intraatrial septum. So usually the subcostal views are very good for intraatrial septum. And you can see two pulmonary veins in the subcostal view, but the best is the crab view, that is for the pulmonary veins. So subcostal views for these things. Then apical four-chamber view, you cannot comment on the intraatrial septum in the atrial four-chamber view because of the dropout of the echo. Whereas atrial four-chamber view is to assess the tricuspid valve opening, mitral valve opening, whether there is any congenitally corrected transposition depending on the position of the valve, and also look for tricuspid regurgitation in the apical four-chamber view. And apical four-chamber view, you look for any chamber size discrepancy, and most of the VSDs can be picked up on the apical four-chamber view, right? And the movement of the intraatrial septum, whether it's moving towards the left or the right, to assess whether there is pulmonary hypertension indirectly. These are the uses of the apical four-chamber view. And slightly tilt above, you get your apical five-chamber view, which will involve the origin of the aorta, where you can comment on your aortic stenosis. Now, ideally for pulmonary artery stenosis, you shouldn't use the apical four-chamber view, because the better view is your parasternal view. I'll talk when I come to that. So these are from the apical four-chamber view. Coming to the parasternal long axis view, the midline parasternal long axis view, you see your mitral valve, you see your interventricular septum, you comment on your left ventricle, you do your M mode to look at the fractional shortening and all those things in the parasternal long axis view. And you can also comment on the interventricular septum, whether there is any ventricular septal defect in your parasternal long axis view. And in your parasternal short axis view, you comment on your tricuspid trileaflet aortic valve, and that's the main thing, and also the coronaries, you can somehow do it. But in the parasternal long axis view, I'm jumping, sorry. In the parasternal long axis view, if you tilt a little bit above from the midline position, you see your pulmonary artery. And that is where you measure all your pulmonary flow and measurements and all those things. And you tilt the probe backward, you see your tricuspid valve. And in that tricuspid valve, you can also measure your tricuspid regurgitation. That is another place to measure your tricuspid regurgitation. And in your parasternal short axis view, if you can see the main pulmonary artery also there, and you can see the bifurcation a little bit. And so these are things which you would be able to comment, and when there is any aorta pulmonary window, you can comment in this position. And ductal view, in the ductal cut, which is slightly high parasternal view, you see the PDA and the left branch pulmonary artery. If you want to look for any left branch pulmonary artery stenosis, right branch pulmonary artery stenosis, the ductal view, adjusting that here and there, and also in your crab view, you see the right and the left pulmonary artery, you can do those measurements. But the crab view is in the in the high sternal area and focusing downwards, where you see the four pulmonary veins, your two lower pulmonary veins and two upper pulmonary veins. And finally, the aortic arch view, where you see the aortic arch. So, Dinakar sir, would you like to add anything?
No, it's excellent. Excellent. Dr. Vikas?
So there was one question on ventricular dysfunction. So because we haven't touched upon functional echo in this chapter.
Dr. Vikas?
Sir.
See, they have asked right ventricular dysfunction, how we can diagnose.
Yes.
Yeah. Okay. Any ventricle. Dr. Ram, you can go ahead.
Yeah, usually the left ventricle dysfunction is easy because it's a straightforward ventricle, and fractional shortening and other things you can calculate from the parasternal view. But right ventricle anatomy is not that straightforward. It curves and then comes, it may not be possible to get straightforward M mode to measure your fractional shortening and other things. There are advanced methods to assess your right ventricular function. You know, one is the TAPC. We call it as tricuspid annular plane systolic excursion. TAPC can be done to assess your right ventricular function, and strain imaging. You know, lots of new modalities are there. But the other way to assess your right ventricular thing
yeah, Dr.
is,
Ram,
yeah,
can I interfere?
yeah, sure.
Yes, sir. Whoever asked the question, sir, for you, right ventricular or left ventricular, whether it is systolic function, whether it is diastolic function, both the ventricle, it is same. Number one, answer. Number two, systolic dysfunction is either you can use in a neonate fractional shortening. Try not to use ejection fraction. How to do it? Both are same. Like how you are doing in the parasternal lang axis view, how you are taking systolic diameter, diastolic diameter.
Hello,
in the
sir,
long
we can't hear
axis
you.
view. Yeah, hello, can you hear me now? Hello?
I can hear you.
We can hear you.
Yeah. Yes, sir. Can you hear me now, sir? Hello?
We can hear you, sir. Go ahead.
Okay.
Yeah. See, both the systolic and diastolic. Systolic, you are doing fractional shortening. Please try not to do in a neonate ejection fraction for the systolic function. Number one is over. Number two, for the diastolic function, better to use early filling and atrial contraction, EA ratio. If you are doing the EA ratio, normally E is more than A. Suppose if the diastole is failing, so early filling won't be there. So atria will come into more contraction, pushes the blood to the either right ventricle. Right atrium will push the blood to the right ventricle. Left atrium will push the blood to the left ventricle. So that way, EA ratio near the tricuspid value, if A is more, that means right ventricle failure is going on. If EA ratio in the mitral valve is more, A is more, that means left ventricular diastolic function is abnormal. That's what see, we are neonatologists. We are not a great super specialist neonatal cardiologist. What we should know, systolic abnormality, how to diagnose. I told you fractional shortening. Then EA ratio for both the ventricles. That's all. If you'll know, that is enough. Yes, sir. Next question, sir. Moderator, sir.
The question they were asking is, can we do pulse oximeter test when the child is on ventilator, or should we wait until we wean off the ventilator? I mean, anybody can answer this.
Ram or Adarsh? Adarsh?
Adarsh, are you there?
Adarsh?
So the question is, can we do pulse oximeter test when the child is on ventilator, or should we wait until we wean off ventilator?
Ram, can you answer, or can I answer?
I think to my knowledge, the pulse oximetry test is just a screening test, and it is meant for babies who are
yes, sir.
Ram
well. is absolutely correct. Ram is absolutely correct. Pulse oximeter is for the only screening. If you are putting the baby on ventilator, what cause you are putting the baby on ventilator? Instead of pulse screening, you have to use the echocardiography. Yes, sir. Next question, sir.
One more important, this pulse wave Doppler in celiac artery to rule out coarctation, and also how to identify dextrocardia in an echo.
Right, okay.
Ram.
Coming to the first question, see, descending aorta below the origin of the duct, right? That is the usual place where we put the pulse wave Doppler or continuous wave Doppler. Basically, whenever there is no coarctation, there will be only systolic flow. There should not be any diastolic flow unless there is a PDA. If there is a PDA, you will see some positive end diastolic flow. Now, in the presence of severe coarctation, the velocity in that area will be crossing 2 meters per second. That is number one, if there is a turbulence. And second thing is there will be a long diastolic tail. So what happens is from the systolic end, it will not come back to the baseline. It will continue till the next systole and then continue as systole. So if you are able to see that in the descending aorta, just after the origin of the duct, or the place where the duct had originally been, that is the best place to screen rather than going for celiac artery, I guess, because this is easier to capture. Celiac artery, again, similarly, you are doing it on the abdominal view. Yes, you will get the same finding, but the best thing is from the descending aorta. I don't know whether anybody has a different view.
No, that's enough. That's it. Ram, what we are doing is dextrocardia. It is very easy if you are going to take the X-ray. So whether it is dextroversion or dextroposition, whether it is dextrocardia, there are three things are there. So dextroversion, that means left ventricle has turned towards the right side. That's it, dextroversion. Dextroposition, just heart is pushed to the right position, like a congenital diaphragmatic hernia or right sided lung hypoplasia. That is dextroposition. Another one is dextrocardia. It is completely inverted heart. Okay, that X-ray it will tell you. Then you, if you are doing echocardiography, first what you have to do is you have to identify the ventricles. How to identify first ventricle? Neonatologist should know. Pediatrician should know. M band is there. M moderator band. It will be there in the right ventricle. That is called more trabeculated area in the right ventricle. That means it will be appearing white thing in the right ventricle. Left ventricle will be borders are very smooth. That's how we are going to diagnose. This is left ventricle, smooth border and rough border and inside more white thing. It is called a right ventricle. That is other way to diagnose, sir. Dextroversion, dextrocardia. Yes, sir. Next question, sir.
So what is the blue and the red color indicate on an echo? Do they correspond to venous and arterial blood? Why are they blue and red?
No, the blue and the red color, they do not correspond to venous and the arterial blood. Basically, it just tells the direction of the flow. Say, for example, any blood flow that is coming towards your probe will be red, and any blood flow that is going away from your probe will be conventionally blue. So this is, you can change it, but conventionally through all our historical practice and ancestors and everybody, blue is away from the probe and red is towards the probe. That's it.
There's a good question which has been asked, which is if facility for echo is not available, how do you diagnose congenital heart disease depending on clinical X-ray and ECG findings? I mean, anybody can answer this question.
ECG. Yes.
Tell the question again, Vikas.
Yeah.
Vikas, can you repeat the question?
Yeah. So the question is, if a facility for echo is not available, how to diagnose depending on clinical X-ray and ECG finding?
Right. I see. As I told you earlier, I know in many centers echo is not available, but to diagnose confidently, echo is diagnosed. Echo is gold standard. But to suspect cardiac, you can suspect that high index of suspicion of cardiac based on X-ray, ECG, and your screening pulse oximetry. But diagnosis is only by echocardiogram.
Sir, Dinakar sir, do you want to add, sir?
Yeah, sir. Sir, one more thing, sir. For everybody who has asked, sir, at least in your hospital, you will be having the ultrasound machine at least. If ultrasound machine is there, please take a vaginal probe 100% in all the hospitals. It will be there wherever the gynecology is there. At least if it is there, put the vaginal probe in the subcostal area or apical area or even suprasternal area. If you know that, just see the structural heart disease in the vaginal probe. To tell you very frankly, I have learnt some part of the echo like that. initially. So you also do it. In case if that is also not there, sir, two things. X-ray will tell you dextrocardia is there, mesocardia is there, or dextroposition is there. Then number two, at least in little bigger child, if you don't, bigger child is there, at least if the PDA is there, you will have a exact PDA type of what is that counter. That is called a counter like. In the left side, you will find slightly bump is there. I think so. Dr. Adarsh might have given that picture how the PDA in a bigger child it will appear in the X-ray. So number one, sir, X-rays also will tell even TOF how the X-ray will be there. If tricuspid atresia, how the X-ray is there. We don't get in a neonate that all the classical form. We do get it in a pediatric cases or a infant cases. So in a neonatal, you should have. And if you are having the ECG, if you are expert, sir, because I am not so expert in the ECG, if it is there, at least everybody knows there are 6 leads. We have to connect either neonate or a pediatric. 6 leads we are connecting. 3 leads, one is for the upper AVR, right upper limb, AVL, left upper limb, AVF, one thing to the foot. And like that, if you will see anything hypertrophied right side, so it will show lead 1, lead 2, AVR leads will be elevated. Suppose if the left side, anything dilated, you can see in the later views, like 4, 5, 6. That is the way, and limb leads. So that is the way we can diagnose something in the ECG. At least try to use scanning, sir. Echo machine is not different. Ultrasound machine is not different. Only if we neonatologists should use the basic machines, what we should diagnose, because we are not able to conclude. We are doing only point of care diagnosis for immediate treatment. Thank you, sir.
Sir, one question. What is the legality of point of care people doing the echocardiogram?
Ram.
Yeah, that's a good question. To my knowledge, again, I think in India, still the radiologists or the cardiologists are legally allowed to do. But for screening purposes, this is like using your stethoscope to assess the child. So what we are doing is not diagnostic echocardiography. We are doing screening echocardiography, which would help in the bedside function, assessment of function, and to decide about treatment. So I would rather not give a, say, for example, you cannot replace a cardiologist. You cannot do the echo and give an official report, right? That only a cardiologist can do. But if you suspect something, you always anyway ask the cardiologist to come and review and they give a report, right? But once the cardiologist has already done a proper report, you can do screening echocardiograms to assess the function, and that can be used to guide your daily treatment. What do you say, sir, Dinakar, sir?
Yes, sir. Sir, medico-legally, yes, 100% we are writing in the case sheet. Sir, I myself, I'll tell you. Because it is already, I have asked the permission of our radiologist of our hospital. I have taken an ethical committee, everything. Even if you don't take, there is no problem. Because we are writing in the case sheet, screening echo done. Screening echo done. That's all. We are not writing anything. Later, after screening it, if it is a life-saving, we will go ahead. In the meantime, we are calling the cardiologist or echo technician. Even if they are not there, if you are going to do the life-saving procedure, by example, echocardiography is there, TGA you diagnosed, patient is closing, patient is dying. In case I know that 99% you cannot do balloon, balloon septostomy, you cannot do, or I cannot do, because we need a cardiologist. At least, thank God, nowadays cardiologists are showing, they are coming in the NICU, they are doing balloon, septostomy by UVC. Whatever we place the UVC, they are doing immediately. Previously, they used to use so many procedures. Like that, at least medico-legally, I request all the pediatricians, neonatologists, your visual stethoscope is ultrasound and echo. Please learn. It will save you. Why I am telling saving you, at least you can save the babies. I am telling you, I watch for it. I am responsible. You write it screening. Ask a second opinion for radiologist or cardiologist. Thank you, sir.
Sir, there's one more question. I think it's for all the participants, for the speakers. Should we do screening echo for all newborns before discharge?
That's a good question. That's a very good question. See, the thing is, if you look at the incidence of thyroid, right, hypothyroidism, it's around 7 per 1,000 cases, right? Or 7 per 750, whatever. And we are doing a screening, thyroid screening test for these patients. And similarly, cardiac, 10 patients out of 1,000. So the cardiac incidence is almost similar to congenital hypothyroidism. And ideally, considering, yes, the fetal antenatal diagnosis is picking up, but still the antenatal diagnosis, they miss something, particularly coarctation and other things are difficult to diagnose in utero when the PDA is open. So logically thinking, yes, screening echo can be done on all the babies, but main thing is the cost and the availability of a pediatric cardiologist to do that. So currently, that is why the saturation pulse oximeter screening has been proven to be safe and efficacious when compared to an echocardiogram. So I think we have to follow those guidelines rather than screening all the babies with an echocardiogram. I don't know what you others think about it.
Dinkar, sir, Dr.
Yes,
Adarsh?
sir.
Sir,
I feel with the prenatal echocardiography going up, already 50 to 60, 70% is being diagnosed in the antenatal level itself. I'm sure with going years, with better skills, the diagnosis can even go up to 80, 90%. Whatever they are missing, pulse oximetry will easily pick it up. So I think
Yes, sir.
currently for a long time to come, this will be the combination.
Sure, sir. I agree.
Vikas?
Dr. Dinkar, do you want to add anything, sir?
Yes, sir.
Perfect.
Sir, so many people have asked so many questions. Sir, how to do the calculation of pulmonary flow. Sir, subcostal view. Sir, apical view. You cannot do any pulmonary flow or any flow. Apical view, you can take only aortic flow, because whenever you see the flow, it should be parallel, sir. It should be parallel. Whenever you are doing the study, it should be parallel. In apical view, when you are putting the pulse Doppler, so it is directly aligning to the aortic flow. But in the pulmonary, it is not. So you cannot do pulmonary blood flow from the apex. Okay, some people do ask, sir, can I do from the subcostal view? Yes, sir. Subcostal view, coronal view, you can try this thing, what is it, with the upper lift of the probe after the upper, what is it, aorta, you will see the pulmonary, there you can do. But which is more convenient to do the pulmonary flow is parasternal short axis, where we will call cup and saucer or Ben's side. That is the best place to see the pulmonary flow, sir. Okay, then
Pulmonary vein, sir. Pulmonary vein views.
Pulmonary vein views, Dr. Ram.
Yeah, pulmonary veins. See, from the subcostal. Yeah. Can you hear me?
Yes.
Can you hear me?
Yes.
Yeah. From the subcostal view, where you see the right atrium and the left atrium, you can see two pulmonary veins coming and joining in the left atrium, right? But if you want to see all the four veins, the best view is what we call it as a crab view, right? Crab view is just, it's basically a high parasternal view, in the sense on the sternum, you put it on the sternum, the marker facing to the right, and you just tilt the probe downwards, right? As if it's looking from above. And there you see the left atrium at the bottom, and you see all the four pulmonary veins beautifully, two lower pulmonary veins and two upper pulmonary veins. We call it as a crab view, C-R-A-B, crab view. So you can check in any echo, or when you come for the echo course next time, we can teach you that.
There was one more question
Ram,
on.
can I add?
Yes,
Ram,
sir.
can I
Yes,
add?
sir.
Yeah.
Okay. See, somebody is asking how to detect the pulmonary veins to tell TAPVC is not there or not. Yes, sir. Good question. See, suppose if I am a beginner, I don't know how to take the crab view. Even if you will take sometimes whether it is what is this, it is really difficult, sir. Whoever asked the question, because whatever we talk, crab view is the best sign. That is correct, sir. What sir is told. But if I am a beginner, what I will do is I will take the apical view or subcostal view. So after taking it, apical view, slowly I will turn my probe after the aorta or just below the aorta. Just below the aorta or at the aortic level or just above the aortic. 3 levels of my probe tilting. Aortic level, just above the aortic level, just below the aortic level. I will concentrate on left atrium. After concentrating on the left atrium, I will decrease my, what is that? Pulse repetition frequency scale. Number one, once I will decrease the scale, scale means whatever I will put 40, 50, 60, I will try to decrease to 10 or 15, sometimes even 8. Once I decrease the scale, so low flow in the pulmonary artery will start appearing very beautifully. So you should not decrease to sometimes 20 it might appear, sometimes 10 it will appear. If you will decrease too low scale, that time what happens? It will become unleashing. Everywhere it will become red, red, blue, blue. Decrease so that you will see one, usually we will see very good left upper and left lower pulmonary vein. After that, we can see right lower pulmonary vein. So that is the way to do, sir. That is enough, sir. Thank you, sir. Next, sir.
How to diagnose PPHN if there is no tricuspid regurgitation? One, and associated with that is how do you actually measure tricuspid regurgitation?
Ram?
Okay. Yeah. So, yeah, good question. Most of the times, you may not be able to get a tricuspid regurgitation. So you go for other parameters. Number one, septum. Which side is the septum moving? Say if the right side pressures are high, the septum will move towards the left ventricle, right? So that is one indirect way of telling that the pulmonary pressure is high. The second thing is in the parasternal view, short axis view, when you come towards the apex, you will see the right ventricle on top and the left ventricle on top, at the bottom. Now, in this view, if the left ventricle is round shape, right, then there is not significant pulmonary hypertension. If the left ventricle and the septum, if the left ventricle is round and the interventricular septum is like a D-shaped septum, then there is moderate pulmonary hypertension. Whereas if the interventricular septum is curving inside into the left ventricle, then we call it as a banana-shaped interventricular septum, which suggests that there is severe pulmonary hypertension. So that is the second thing. The third thing is you measure the flow velocity. You measure the flow wave from the right ventricular outflow tract, that is the pulmonary artery, and from that flow wave you calculate the right ventricular ejection time, right? There is a in the echo machine there are software, you just it will calculate the right ventricular ejection time and then the right ventricular acceleration time. So from the baseline, the peak acceleration, the time taken for the right ventricular flow to attain peak acceleration. So if you take this ratio, right ventricular ejection time and right ventricular acceleration time, if the ratio is less than 0.3, it means that there is severe pulmonary hypertension. If the ratio is above 0.345 or something, no pulmonary hypertension, and in between it's moderate pulmonary hypertension. And also the other thing that you can do is, sometimes if you look at the flow velocity, right? If there is a mid-systolic notch in your pulmonary flow velocity, then that suggests that there is a severe pulmonary hypertension. And on top of that, the PDA flow, if it's a pure left to right PDA, then there is no significant pulmonary hypertension. If there is pure right to left PDA, if it's a blue color shunt, right to left PDA, then it's suprasystemic pulmonary hypertension. And if there is a bidirectional flow, then I would say it's moderate pulmonary hypertension. So these are the rough ways that you can describe your pulmonary pressure. And coming to the estimation of the right ventricular systolic pressure from your tricuspid regurgitation flow, so you basically take the maximum flow velocity. So usually you get the velocity in meters per second. The Bernoulli's modified Bernoulli's formula, 4 into V squared. So 4 multiplied by velocity squared is your pressure gradient, right? For the tricuspid flow leak to happen from the right ventricle to the right atrium. So you add the fudge factor of 5 millimeters of mercury. Say, for example, if the pressure gradient comes as 40 millimeters of mercury, you add 5 millimeters for the right atrial pressure. So 45 millimeters of mercury is your estimated right ventricular systolic pressure. Sir, anything, sir, you want to add?
No, sir. What you told is good, sir. Because tomorrow, once again, we have a class about the PPHN. Only thing, every time you don't get the TR, that is what sir is told is correct. Every time you don't get TR, even though pulmonary arterial hypertension is there, you might not get a TR. That is one carry home message. So that time you will see the pulmonary flow. How you will see pulmonary flow? Parasternal short axis, I told you earlier. That one, that we will tell you even because tomorrow I think so they are going to tell you. PDA he told. Sir, next question, sir.
Usefulness of NADA's criteria in today's world now. For diagnosis of congenital heart disease, NADA's criteria.
Adarsh, Dr. Adarsh.
You take Dr. the question, Dinikar. You take the question.
Okay, NADA's criteria, sir. Sir, we have to use all the whatever the criteria are there. We better to use it, whether it is acyanotic, cyanotic, or congenital heart disease, whatever. All the criteria are important. We should not leave after the echo has come. Many people are telling, sir, why should I see? Echo has come. Sir, why should I see murmur? What is the use of hollow systolic murmur? What is the use of diamond-shaped murmur? I cannot see the diamond-shaped, only I will hear. What is the use of open snap? What is the use of ejection click? What is the use of third heart sound? No, all these things we should know clinically. But however, echo is our luxury. That is the reason NADA's, at least all the postgraduate, I request we should follow the NADA's criteria. Next, sir.
How to obtain a bicaval view?
Okay.
Sir,
good question.
Ram.
Yeah.
Answers.
Yeah. So what you do is in the subcostal view. So for the normal IVC and the IVC and the aorta, what you do is the marker will be pointing towards the right side, right? So so that's the way you normally look at your IVC and your aorta. So what you do, you normally to see the IVC and the aorta in the longitudinal view, you turn the probe to the marker should be turning 90 degrees upward. That is your IVC aorta for the longitudinal view. But same way the probe, if you turn it downward, say the marker should be facing the foot end of the child, right? And tilt the probe towards the right atrium. So there you will see the SVC, right atrium, and the IVC coming and joining. It is difficult to explain, but the marker should be facing the foot end of the probe, and the probe should be facing the right atrium. And then if you tilt up and down, you will be able to get the IVC and AVC draining at the same time. That is called as a bicaval view. Again, this can be demonstrated in any of the echo course.
I think most of the questions have been answered today, and I think we have had an excellent feedback. We had about almost 350 participants today in today's session.
Wow, okay. Right.
So there were a lot of, I don't know how much, I think Prashant will tell us how much logged in through YouTube and Facebook.
Yeah, more than 100 have watched. Anyway, I think
with Prashant's permission, Dr. Dinakar, Dr. Adarsh, and Dr. Ram's permission.
Because there is somebody is asking some question because Wolf's
yeah. So
Parkinson's white syndrome.
Go on, sir.
Yeah, that one, sir. Please, sir. That one day after tomorrow, probably day after tomorrow, we are having arrhythmia class, sir. Arrhythmia class. So in that arrhythmia class, Dr. Prashant YN is going to answer for you, sir. Wolf's Parkinson's white syndrome. Yes, sir.
Dr. Dinkar, sir, there was also a question on TE index or myocardial performance index. I think we can do that in the PPHN class.
Hello.
I think so. Yes, sir, we can do it. Otherwise, myocardial performance index means it is a overall heart, how it is functioning, sir. Overall heart, how it is functioning, number one. Number two, myocardial performance index will take the square root of the heart rate, because myocardial performance index, sometimes what happens, if the heart rate is very high, we might not get. If the heart rate is low, it is very difficult. So we will have to do the correction with a square root of the heart rate. So this myocardial performance index, we can, if the echo class is there, then usually we can easily teach, because IVRT plus IVST means relaxation time means contraction time. So that is the way. So we have to do, sir. Only thing, this question we have to teach in the echo class only, sir. Overall thing for the theoretically at present in the webinar, what I can tell is it is an overall myocardial performance. So I told you systolic dysfunction, diastolic dysfunction for each ventricles. Now this is overall, sir. Overall. Next question, sir.
I think we have answered
yes, sir.
most of the questions, sir.
Yeah, because you can,
just Dr. Prashant, if anybody wants to ask anything,
sir, 1 second.
Let
sir,
them ask.
2 messages. No, most of them are looking forward for the next class also.
Dr.
That
Guru
is what
Prasad
they're
sir
telling.
is there. Guru Prasad sir is there on the line.
yeah, sir, I've unmuted Guru Prasad, sir.
Yeah. I'm audible, Prashant?
Yes, sir.
Yes, sir. Please.
Good evening, Prashant and Dinakar. Again, a wonderful symposium on neonatal cardiology. I think we should congratulate Dr. Adarsh, Dr. Rama, Krishna, and Dr. Vikas for doing an excellent job. Yeah.
Thank you, sir. Thank you.
I'm working as a faculty in the medical college for the last 30 years. We have conquered pediatric cardiac problems. When we were residents, we were really losing patients because of VSD, tetralogy of Fallot's, transfusion of great arteries. We have really come a long way. But our concern even today is critical congenital heart disease. It was nice to make a diagnosis. I'm very sorry to say we lose innumerable number of patients even before they reach a tertiary center. I think you people who are really doing such wonderful job in pediatric cardiology should come out with very concrete way of helping out these patients. See, we are not even able to shift these patients to a tertiary center. And now government schemes are also not really there for a good number of these patients. I have lost innumerable number of patients who are ductus dependent. At least we are making diagnosis. It is nice to make a diagnosis. Hypoplastic right heart syndrome. In fact, we shared and published a paper long back. Fatal congenital heart disease on the rise. So we have had fetal newborn autopsies done. So I request all of you to really take it in a big way, especially critical congenital heart disease. We have conquered most of the pediatric cardiac problems. Our concern as a senior member of the group is we have to come out with very concrete. It is not enough that we make a diagnosis. How to really help these patients, both in terms of support to the family, to get them operated. I know each package in a good hospital in Bangalore costs 3 lakhs, 4 lakhs, 5 lakhs. How to manage those issues are very important. That's one. Number two, I think Dinakar, some of the residents raise their questions on NADA's criteria. As teaching professors, we do continue to teach this NADA's criteria as bedside, because even echocardiography will be luxury in good number of situations. Those who are working sick hospitals, and the cardiologists coming and doing an echo is all the more a luxury even today in majority of the hospitals. So in those situations, we continue to teach residents NADA's criteria, major and minor, for like Duckett-Jones criteria for rheumatic fever. I think it has its own significance to make a probable diagnosis of congenital heart disease. And Dr. Adarsh, just last week we had a mother with atrial myxoma, 32 weeks of gestation, and they came for counseling. What should be our plan in such situation? Antenatally diagnosed rhabdomyomas. How to really go about? That's my question.
Sir, we have Gautam Suresh sir as well. Sir, good evening. Good morning, sir.
Good morning. Can you hear me?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
I'm just listening. I'm here to learn. Okay, so.
Sure, thank you, sir. Yes. Sir had a session last Sunday about the COVID, because he's advisor for Government of America in Texas. Anyway, thank you, sir. Dr. Vikas,
I had one question whether we can go take home message for the participants. Is one question for Dr. Adarsh and one question for Dr. Ram. If I have to do one test screening tool or anything to approach or diagnose a congenital heart disease, what would be that one test? And the same thing for Dr. Ram is, if I have to use just one view, one window, what would be that window that I can do an echo?
Okay. So who should...
Dr. Ram, you can go first. Go for it, Dr.
Okay.
Ram. Just one view that I would can pick up most of it.
See, parasternal long axis view, right? You do get most of the information, parasternal views, right? Because you get, you rule out TGA, you rule out truncus, right? You rule out aortic stenosis. You can see turbulence in the aorta. You rule out pulmonary stenosis. You know, parasternal view, that view alone, you know, I don't say parasternal long axis, but from the parasternal view, you can see VSD, right? You can measure tricuspid regurgitation from the parasternal short axis view. So all those things can be done in parasternal view. The only thing which you cannot properly do from the parasternal view is the arch of the aorta, the descending aorta, and the pulmonary veins properly, and the abdominal situs. But most of the, in fact, the adult cardiologists, because they don't see total anomalous pulmonary venous drainage or congenital heart disease that frequently, most of the adult cardiologists, they use only the parasternal long axis view to get all their information most of the time. But one view alone is not enough. It has to be done fully, because there are chances that you may miss certain things in one view alone. That is the reason why we have to look at the heart in different views, which will add on further information. And coming to one screening test, I think if it's a cost-effective screening test, pulse oximeter screening is the best. But if you want a diagnostic screening test, by diagnostic screening test, and echocardiogram is the one.
Dr. Adarsh, you there? Dr. Adarsh?
Yeah, hi. Tell me,
So the question was, if you if you are asking for one screening test and one echocardiographic view, what would be the one?
They're getting confused.
So if there is one screening tool that you would use,
one
just
screening
like a take-home
tool is
message.
pulse oximetry.
Right. Any of the panelists would like to add anything more? Dr. Dinakar, Dr. Guru Prasad, sir?
Nothing.
Fine,
See,
I
what
think.
Ram has told is very, very clear. We cannot carry home after so much 2 hours talk. We cannot carry home one view, one window. Please, sir, everybody, I am requesting. First, we should have theoretical knowledge in our brain. Theoretical knowledge in our brain. What I mean is, suppose if we will tell left atrium is small, or how to diagnose core triatrium. Somebody has asked a question. Sir, core triatrium, we can do diagnose in the subcostal view also. Number one. At the same time, we can do use in parasternal long axis or parasternal short axis also you can diagnose. Even in apical view, you can diagnose. Somebody has asked that diagnose, how to diagnose core triatrium. Like that, please, first you should have a theory knowledge of hemodynamics of each congenital heart disease. Once you find one thing, with that, what happens, our brain should think. So if the left atrium is small, why it is small? Then we should see on the, what is this, mitral valve is there or not. Okay, why left atrium is small? Just above that, any mesh I can see. Just above that, put the color, whether I can see confluence. So like that, first, anybody who is doing, we should have a solid theoretical knowledge. Then we should have a anatomical structural knowledge. After that, we will go with the step by step positions of the echocardiography. Then only we will become, at least screening, we will be fit. So I request all my colleagues, please have a theoretical knowledge, then views, then catch a probe. Thank you, sir.
Thank you, Dr. Dinkar. Thank you very much. Prashant, would you like to add anything?
Yeah, I think it's time up. It's already 7:15. So I always tell knowledge is like an ocean. So it's very difficult to drink the entire ocean. So you have to drink over a period of time, how much our capability and capacity we have. So I think we have reached that capability and capacity now. Wonderful session you made, because we were targeting on reaching maximum practicing pediatricians who are practicing neonatology as well, because that is how we all have started. So the session was wonderful. Thank you very much on behalf of NNF Karnataka. Thank you, Dr. Adarsh, Dr. Ram, and Dr. Vikas. All the participants who participated across India and outside India. Thank you very much. And please join us for the next upcoming session. That is this Thursday, same time, 5 to 6 o'clock. Please join us. Please be there. We'll be discussing on echo findings in PPHN and PDA, plus neonatal arrhythmia as well. Thank you very much.
Thank you. Thank you.
Thank you.